Good morning, everybody. I want to thank the organizers for inviting me and for all of you for spending your weekend at this great conference. So we're going to talk about managing the acute severe UC patient. I'm going to review some of the old data as well as what we've learned recently, and I hope this will influence your practice. I do have some disclosures which are also, of course, in the booklet for the program. So let's start just by reminding ourselves of what our current definitions are for clinical severity of ulcerative colitis. It's a modified definition from the original Truelove and Witts criteria. I say modified because the addition of the category of fulminant ulcerative colitis was not in their original description. And this is, of course, what's appeared both in the ACG guidelines in 2004, and they were unchanged when they appeared in 2010. And there will be some new guidelines coming out within the next year that I think will include something like this. But I'll point out to you that despite the fact that everyone in this room appreciates the value of how severe the mucosa can look when someone has severe UC, the endoscopic appearance did not make the severity scale in the clinical categorization of ulcerative colitis in the ACG guidelines over all these years, and we're hoping to change that in the upcoming guidelines. Fulminant ulcerative colitis actually refers to a progressive and unremitting severe UC. In other words, not only is it severe, but there's a time course where it's not responding to therapy and where the patient is getting sicker. Most of these patients will have some component of abdominal pain. Remember that pain in UC is a red flag, and if you can distinguish it from specifically just cramping, you should be alerted and worried about that patient. In addition, depending on whose study you look at, it's between 5 and 15% of patients who may develop a fulminant course, and these are obviously people who can be quite sick. It would be nice with our emerging therapies and some of the newer options we have to be able to understand who actually might have a fulminant course that could be stopped or reversed, and who would just do better off going to surgery early, even when we consider the fact that none of our patients really want surgery. Now, we all appreciate the sick patient who comes in with a perforation, those types of things. We're not going to focus on that group today. We're going to focus on the group of people who are sick, severe, usually end up hospitalized, and what are your treatment options and how can you use them in the most intelligent way. So how do you assess these patients? Well, the first thing is, a lot of times we kind of lose the forest for the trees. The patient is sick, they're coming back to clinic, they're calling your nurse or your assistants or your colleagues, and you're not necessarily keeping track of the fact that, yeah, you know what, their hemoglobin's been drifting down. This is somebody who is walking around somewhat tachycardic and telling you they're still getting by. We have to recognize that these patients who are not doing well on outpatient management need to be in a hospital setting where we can evaluate them and provide more intensive therapy. That includes patients who are on corticosteroids for more than a week in my practice. If I decide to give somebody prednisone at a dose of 40 milligrams, or if I'm going to start an anti-TNF or biological therapy, and they're not moving in the right direction within a very short interval, we have a discussion about bringing them into the hospital for a better assessment. Second thing is to make sure you're not missing something that's contributing to the cause of this, and we'll look at that in the next slide. Of course, you don't want to be masking their problem and making it worse with anticholinergic agents or narcotics, which unfortunately they can get in the ER when they've visited, they can get from their primary care doctors. Well-meaning people will do things that make these patients sicker. And we obviously want to keep an eye on them so that they're not moving in the wrong direction over time, either as an outpatient or an inpatient. We should be suspecting C. difficile. Remember that up to 25% or maybe more of our patients with IBD who have C. diff have no identifiable risk other than the fact that they have IBD, and that in and of itself is a significant risk factor for C. diff. We should obviously be monitoring their labs. X-rays can play a valuable role, but don't forget that we are clinicians, and really I've never seen somebody with a toxic megacolon who didn't have an obvious physical exam finding as well. So don't just rely on your ER to send off another CAT scan or for somebody to check a KUB. When you examine them and they're tympanitic and tender, you know what you need to be doing for this patient. And obviously early endoscopy, not a full colonoscopy, but early flex sig with biopsy is very important. So some of the things to keep in mind is that most patients who have this, we don't know why this happened. They can be patients with newly diagnosed UC who move to a fulminant course, and the most frustrating patient is the one who's been doing well for years on maybe just a 5-ASA, and something triggered this, and now they're quite sick. Depending on whose analyses you look at, there's up to 1 to 2% of our patient population with UC who will present this way. And the patient and you are very frustrated because they had such a benign course for so long. What are we missing? Well, it does happen. Think about infections. I already mentioned C. difficile. CMV rarely will occur if the patient isn't already on immune suppression. But if they're on any immune suppression at all, you should be thinking that this is high on your list, even though we still struggle to understand the relevance of it. But a true CMV infection meaning they have elevated liver enzymes, they'll have presence of the virus in the biopsies of their colon, and obviously measurable PCR, will be somebody who may respond to antiviral therapy early, and you want to acknowledge and find those patients. I've mentioned narcotics. Antibiotic exposure can certainly trigger something like this. Don't forget that sometimes your patient hasn't been telling you that they're smoking, and remember that people who quit smoking with a history of UC will get worse, and sometimes they don't tell us that, or we don't remember that that's a trigger, and we'd like to know that that may have happened. Obviously, the patient who walks in the door with new UC who's getting worse, you should be asking about their smoking history, and that curious relationship is a very important one. Not to say that they should start smoking again, but we certainly have that experience and we've published it. Obviously, if they're not taking their maintenance therapy, and sometimes they're afraid to tell you that, or it's been out of their control, like insurance won't let them get their medicine, and we should know that as well. And the last one that I think is worth mentioning is that remember that pregnancy is a state of altered immunity, and this can trigger a fulminant course in some patients. Remember that C. difficile in IBD is worse than C. difficile in non-IBD patients, so the people who are post-op who got antibiotic exposure and don't have IBD who get C. diff tend to do better, but your IBD patients with C. diff have a much worse course, more likely to end up with surgery and even to die from this complication. The challenge is that we don't even know what the colonization rate of C. diff is in our IBD population. So we may have some people that test false positive for C. diff in the setting of a severe colitis flare, and we don't necessarily know that that's driving it, but we have to treat it. So you should be looking for it often, suspecting it frequently, especially when your patient's flare doesn't match what their historical flare has been. That patient who calls you and says, my usual flare is urgency and bleeding, and now I'm having watery diarrhea and a foul smell. Think about C. diff early, and after you get off stool sent off, start them on empiric therapy. You may not be aware of this because I couldn't find the full publication until very recently, but this had been presented at ACG 2 years ago. This was a retrospective, so this is not a prospective randomized study, but a retrospective study looking at the distinction between treating with metronidazole or vancomycin for C. diff in UC patients in the hospital. And you can see that the orange, which is metronidazole, the green, which is vancomycin, the metronidazole patients had significantly more 12-week readmissions, 30-day readmissions, numerically but not statistically significantly higher colectomy rates. And therefore, it's clear that vancomycin is your preferred therapy for at least inpatient C. diff. I will tell you that in our practice, everyone who gets C. diff with IBD gets vanco. We don't mess around with metronidazole. And I will go to the mat with insurance companies who tell me otherwise. You've seen this. This is just to remind you what x-rays can look like, but also to remind you that you don't need this x-ray if you're examining a patient. They're going to be tympanitic. They're going to be distended. You're going to tell that this patient has a really ugly-looking colon, and you want to worry about this patient. You also want to recognize the findings on a CT scan with these very dilated loops. Don't let somebody tell you this is necessarily an ileus. This can be due to distal inflammation in the colon. Look at this picture very carefully. The left colon, I don't know if the pointer works, does it? Yeah. The left colon here is the diseased area. Okay, you see that? And the proximal colon, of course, is dilated because of a lack of motility through the diseased area. So this is also somebody who has a very poor prognosis, and you need to be worried about it. So when we talk about frequently progression of IBD, we usually say it's Crohn's. Crohn's progresses over time. But the reality is that more and more we appreciate that UC does this too. And that left colon is somebody who's had long-standing bad UC that's getting worse and is obviously affecting the rest of their bowel. Patient who presents that way, by the way, will have the paradoxical constipation, bloating feeling, and it's due to the inflammation of the distal bowel. Now remember that we have endoscopic severity indices. We don't necessarily use them in clinical practice, but we probably should be for uniformity and for other reasons. And in general, we try to distinguish between normal, mild, moderate, and severe. And most people are fine with normal and severe. Mild and moderate gets mixed up in the middle depending on who you're asking. But the distinction here is not to necessarily appreciate the difference between mild and moderate, is to realize that when you get somebody who's severe, whether you should be moving in one direction towards surgery or whether you want to try medical therapy and how far do you go. There's a lot of unanswered questions, and that's an entirely other lecture. This is a patient of mine who had a history of progressive colitis and pain despite 5-ASA and then admission into the hospital with IV steroids. I show you this just to show you, of course, how bad his colon looks. You can sometimes get confused and think, well, maybe this is Crohn's colitis in the acute setting when someone's first presenting. I also show you that picture on the left, which my fellows have called the Rubin view. That's the forceps going into the ileocecal valve. I take that picture for my pathologist as much as for me to confirm that the valve looks normal. Sometimes it's patulous and sort of like a fish mouth looking at you, and I do that as well for my pathologist and for me in case there's going to be mild ileitis that would be confused for Crohn's to help us clarify that it might be backwash. This patient, because of progression on IV steroids and abdominal pain, went to surgery. We didn't even try other medical therapies in this particular situation. So patients who have this severe condition need to be hospitalized. They need to have your surgeons on board. The surgeons don't like to be called after the patient has decompensated. They are much happier to know the patient and to be there. I also would advise you to tell the patient that you're calling the surgeon to just meet them, as opposed to the surgical resident walking in the door and they didn't know they were coming. That doesn't usually go so well. You also want to stop potential offending agents. Remember, some people get worse on 5-ASAs, 3 to 5% of our patients, and the other agents we've talked about already. If you suspect that they may have a toxic megacolon or they have pain, there may be a role for broad-spectrum antibiotics, but remember that in multiple studies, antibiotics themselves don't appear to be a treatment for this condition. This is more to cover them for translocation or for the possibility of microperforation. And obviously early flex sig, and even empiric therapy for C. diff while you're waiting for that result to come back from your laboratory. Patients who are more likely to have colectomy are the patients who continue to have fever, heart rate greater than 90, a CRP that's elevated, recognizing that some people don't make CRP, the endoscopically severe lesions, obviously, and very importantly, a lack of response to IV steroids by day 3. You don't need to be waiting a week on IV steroids and day after day walking in the door and saying, well, let's give it one more day. There are multiple studies now that have analyzed this, and by day 3, if you're not seeing some objective and subjective improvement, you should be moving on to something else. Now, here's another picture that I thought you'd appreciate. This was a young woman who early in my career walked in the door 10 weeks pregnant. She had a history of UC and hadn't been taking any of her meds, had been walking around with active UC, and early in her pregnancy developed this picture that you see here on flexible sigmoidoscopy. I point this one out as well, just to say this isn't Crohn's. This is actually terrible UC with complete loss of the mucosa. Those are potholes. And this woman also went directly to surgery during her first trimester like this for obvious reasons, but she ended up with an ileostomy and carried that through the rest of her pregnancy. And then after a successful vaginal delivery, she had a completion proctocolectomy with a J pouch, and we still follow her, and she's doing very well. So the treatment options that I'm going to cover now: IV steroids, anti-TNF, cyclosporine, some of the new considerations, and of course surgery I'll briefly mention at the end. So although we use steroids like they're going out of style, the reality is that the majority of studies are quite old looking at steroids. We know that they work, but they don't work in everybody, and we also know that they are prognostic markers, meaning when a patient doesn't respond to steroids, that's an indicator for you that they might need something else. Also remember that people can die from this condition even today, and we have to be very careful about that, and that's another reason why surgery is sometimes the right choice out of the gate. In this meta-analysis, there were some patients exposed to cyclosporine, but I'll show you better data on all that later. And there were a variety of predictors of medical failure on IV steroids, including more extensive disease, stool frequency after a number of days, and some of the other risk factors that I already told you about. Now, some people ask, well, how much steroid should you give? You'd be surprised, perhaps, if you haven't heard this before, that there's actually very little data. There's one study that shows that 40 milligrams daily of Medrol or its equivalent is as good as 60 milligrams. In our practice at the University of Chicago, we're using 40. And there's only one study as well that looked at the difference between doing continuous infusions, which is what we did when I was a fellow, and what we're doing now, which is BID dosing, so 20 BID bolus. Now, the only reason we switched at the University of Chicago was we found that when we had continuous infusions going, the nurses sometimes lost track of who changed the bag last. So there'd be an empty bag of steroids hanging there all day long, and everyone thought it was running in, and it was empty. So it's a quality indicator, or change in our practice for quality measures. So now giving 20 BID, we found that we don't have any issues with that anymore. That's at least our place. So you might think about that if you're going to make a decision. In addition, how long you should do it, I told you already 3 days should be sufficient. I use CRP in the hospital setting. When the patient has an elevated CRP at admission, remember that it has a short half-life, and you can check that every single day to see how your patient's doing. And within 24 hours, your CRP can start coming down, and it can be very reassuring to see that you're making some progress in that regard. Now, we have some data on our biological agents, but remember that the majority of data and the strongest data are all for outpatients, so not for the patients we're talking about right now. So these studies, the ACT 1 and ACT 2 trials, which were the pivotal trials for Infliximab, were actually for moderate to severely active outpatient ulcerative colitis patients. Specifically excluded were patients expected to be hospitalized or to need surgery. So you recognize these data. 5 and 10 milligrams per kilogram of Infliximab was superior to placebo, but this is not for the patient we're talking about. If you look at the severe UC patient in the hospital setting, you can appreciate a variety of smaller studies, some of which have no controls, but the most consistent results were seen across the studies with some benefit. But you'll also notice, look at Bruce Sand's study in 2001. The patient received 1 infusion of Infliximab, and then they looked at the response rate. And look at the Yanaro trial in 2005, the second one from the bottom. 1 infusion of 5 milligrams per kilogram with the outcome measure of no colectomy at 90 days. And these were patients who were randomized to Infliximab or a placebo. So you would say, well, this is not what we're doing today, and I would agree with you completely. But these are the data so far. Now, the Yanaro trial, the one that's most often discussed because it had the placebo arm, also had Followup. So with a single infusion of Infliximab, look at the 90-day colectomy rates on the left and the 2-year colectomy rates. It's pretty dramatic that there were some patients who clearly responded. Now, my other comment to you is that in Europe, patients with UC get hospitalized who are less sick than in general what we see in the US. So you have to extrapolate and understand that when we look at European studies, these patients are often different. In fact, in the early days, they hospitalized everyone who was going to get Infliximab. So you might say, well, this is more like the ACT trials than it is the severe fulminant case that we would admit here in the US. So just keep that in mind as well. There are some predictors of Infliximab response, and you should keep this in mind. Although not clinically available yet, there are some genetic variants that might predict the likelihood of responding to Infliximab. The elevated activity index, of course, and patients who are p-ANCA negative are less likely to respond to Infliximab. Now, although that hasn't been validated as a practice guide for us yet, you can imagine understanding that in the future now that we have other biologic agents, or maybe even considering cyclosporine or surgery in some patients, that a negative ANCA status, and some may say, well, that's the patient who's not the typical UC patient, may not do as well. So that's kind of interesting. Oh, sorry, I'm saying it backwards, aren't I? It's the negative ANCA status that does better, the high ANCA status that does worse with Infliximab. So just to clarify that. And in pediatrics, Infliximab was less responsive with increased genetic loci that are not available clinically yet. And of course, the first lesson I learned as a fellow was about albumin. So somebody with a low albumin is less likely to respond to your Infliximab. Now, why might that be? Well, Gordy Greenberg in Toronto has done some work in this area, and that's led to a lot of discussions. People with low albumin and bad colitis may be actually leaking protein in their stool. So the patient who has a low albumin may be sick and just have low albumin because they're sick. They may have a low albumin because they're not eating. They may also have a low albumin because they're leaking protein. And if you're using a protein-based therapy like Infliximab or any of our biologics, they may actually be losing the drug in their stool. So I often say that this is like trying to fill a bathtub when the drain is open. You can't get enough drug in. So if you look on the left there, what you're actually seeing is the serum Infliximab level over time in a patient who gets a first infusion. And the multiple measures over the days there shows how the level falls. And you can also notice that they were measuring antibodies to Infliximab over that time period too. So although the level was falling here, the antibodies to Infliximab stayed low. By the time they got to the second Infliximab dose, the level had fallen so low that essentially it was like giving them a new dose, almost like we would call episodic therapy. I call it pseudo-episodic therapy because it wasn't intentional. It's just that they bottomed out their drug level in between their first 2 infusions. And then look what happens to the antibodies to infliximab with that episodic exposure. Goes straight up, and then despite repeated dosing of the infliximab, they can't get a mountable level. So one of the reasons people may not respond to infliximab in a hospital setting or with severe UC, maybe even as an outpatient, is if they're losing all the drug and they're essentially then developing antibodies, or they're not mounting enough drug in their body to actually have a response to therapy. Now, some work in Amsterdam following up on these observations has been presented at DDW for the last 2 years, and what they did was they actually measured infliximab in the stool. And they demonstrated that the more infliximab you can measure in the stool, the higher the CRP and the lower the infliximab in the serum, which makes sense. So you can start putting together a picture here where you could imagine testing somebody and knowing where the drug is going and why they're not responding, and distinguishing between someone who has a mechanism failure, meaning blocking TNF is the reason they're not responding, from somebody who has a pharmacokinetic or dose failure, meaning you're not getting enough drug in their body to do anything. If you believe it's the former, you should switch mechanisms and get them onto something else. And if you believe it's the latter, you may go back to that mechanism or use some other way to get them into remission and then consider that treatment in the future. It's a very important observation and something we're going to talk more about. There are some unanswered questions about this, however. We don't know yet if you can just overcome this. I have colleagues who just say, okay, sick UC patient in the hospital, give 10 milligrams per kilogram, and if they don't respond, do it again in 5 days. Well, aside from the fact that that's pretty expensive, the reality is we don't quite know if that's enough to overcome this problem in some patients. Maybe we need to know where the drug's going before we start giving them such high doses, but I know some people have had some success with that anecdotally. Can we predict who's going to have this problem? So is it just the low albumin, or could we use something like an alpha-1 antitrypsin level in their stool as a marker of protein loss to know who might do this? Can it happen equally with all protein-based monoclonal antibodies? We think so. So if it's happening to one, or you suspect it's going to happen because the data is in infliximab, it probably will happen to all. And can we bridge with non-protein-based therapy to a monoclonal antibody? And I'll show you one slide on that in a minute. We don't have sufficient data for adalimumab or golimumab, the other drugs that are approved for the treatment of moderate to severe UC in the U.S. for inpatient management. So although it may be what's on formulary for you, I know that's a situation for some people. It may be what you're left using, but I wanted to tell you there's not good evidence for it yet, and we have to keep that in mind. And reality is that they're probably similar to infliximab if we could get the dosing the right way with these therapies, and that hasn't been proven yet. Now, just a couple other points. One is that we know, as with Crohn's disease, that in UC combination therapy works better than mono. Although this is a criticized study that may be underpowered, we certainly appreciate when you have more than one immune suppressive on board, you're more likely to be successful. But again, I point out to you in the title there, these were outpatients. What about our newest agent, vedolizumab? This is the alpha-4 beta-7 anti-integrin. This is not an anti-TNF. Again, we're talking about outpatients with moderate to severe UC. Very successful therapy compared to placebo across all of its primary and secondary endpoints. So we'd be optimistic to think this might be something to use for our severe patients in the hospital. Well, those were not the patients in their pivotal trials, just like Act 1 and Act 2 with infliximab. So we don't quite know that yet. We do know, however, that if you have patients who are anti-TNF naive, they're going to do better with the therapy than those who are failing other treatments, which doesn't surprise you, right? The patient failing other treatments is likely to fail the new one, although this was still somebody who did better than placebo in general with this therapy, they did better when they're naive. The question then becomes, well, who would you give this to instead of an anti-TNF? In the hospital setting, we have no data to guide us, and I'm not here to tell you that you should be doing that. I am here to tell you, though, that we're interested in it, and we can think about it in a minute. Now, for cyclosporine, only a few slides because I suspect most of you aren't using it, but I do want you to know that cyclosporine is not a protein-based therapy, and it's having a bit of a resurgence in this era now, because we recognize that maybe for some patients, using a treatment like this as an induction agent would be a good bridge strategy to a maintenance therapy of some other management. So first of all, you want to think about who might be the right patient. It's not the patient like that pregnant woman who needed to have surgery. It may be somebody who has an option for maintenance that hasn't been used yet, traditionally thiopurines. And now in our practice and in collaboration with some colleagues, we're looking at cyclosporine as a bridge strategy to vedolizumab. And that we think is reasonable because vedo, we believe, is more specific targeted therapy and doesn't have the same systemic immune suppression as some of our anti-TNF agents might. So there's some things to think about with cyclo. Now, the old studies looking at it, again, small numbers, demonstrated consistent benefit with cyclosporine and even better when you added it to steroids. And when you look at follow-up, some people say, well, yeah, but by 7 years, most of those patients have lost their colon. I would argue that for the first 7 years, if you still had your colon, you're a pretty happy patient, as long as you're not letting them live sick. So there is some role for this if you could just get them to a better maintenance therapy. Now, there was a recent study in Europe, and remember I told you these are not the same sick patients we do in the US, but compared IV Infliximab to IV cyclosporine for induction of the severe IV steroid refractory patient in the hospital, and they found that they were statistically similar in their success rates. They were also statistically similar in their safety rates. So those who have always liked Infliximab and been not so much in favor of cyclosporine said, look, they're the same. And those who have been in favor of cyclosporine for some patients said, yes, look, they're the same safety-wise too. So it really has to do with understanding who you might treat and picking the right patients. Now, there's also been some follow-up. This is a retrospective analysis from Amsterdam where they showed that depending on which induction strategy used in the hospital, the likelihood of being well in follow-up and not having a colectomy differed. Patients who got Infliximab and responded to it in the hospital setting did better in their follow-up for up to 5 years and longer. So they suggested that if you have a patient who responds to Infliximab in the hospital setting, they're more likely to still have their colon when you follow them out than the patient who got cyclosporine. Remember, though, that these were retrospective analyses, so you might wonder why they picked one agent over another in the first place. What about Tacro? I know my pediatric colleagues have some more experience. We've been using it a lot. I became a fan of Tacrolimus while I was waiting for vedolizumab to get approved because I didn't have anything else to offer patients and we were trying to get them to the finish line for the new drug. But there's been some studies of Tacrolimus, both as induction and even maintenance therapy, at least out to a year. And we know from studies in Japan and studies now in the US and studies in kids on the East Coast that Tacro may have a role for some patients with moderate to severe UC. It's not an inpatient therapy. It's the same class of therapy, though, as cyclosporine. So you can imagine how we might use it. Now, we presented at ECHO and we'll be presenting at DDW our experience using cyclosporine or Tacro as bridges to vedolizumab. And I'll just summarize by saying that it works and it was safe. So again, the idea here from our perspective is different mechanism for an induction strategy, which we believe is safe in combination with vedo because of vedo's unique mechanism of action. Obviously, this is a small number of patients, and we need to do more, and we're now collaborating with the group at Sinai in New York, and we'll be putting together a larger number of patients. My last slide is really on when you consider surgery, or my last point, and we've talked about surgery. I would just say that in this day and age, I think all our colorectal surgeons are in agreement that for the sick patient failing medical therapy, a staged approach is appropriate. Going to the one-stage procedure is not the right way to go when people have been on these immune suppressive agents. And when you start teasing apart the safety data, the reality is that when you do an ileostomy and leave a Hartmann pouch in and then come back when they're off medical therapy, these patients do very, very well, regardless of their induction of their previous medical therapies. So the answer to the pre-op question, the pre-test question, was that actually these agents are considered safe pre-op if you go to a staged surgical procedure. And then this retrospective assessment from our center at U of C demonstrated that on the left are infectious complications, on the right are non-infectious complications. And essentially what we found in about 78 patients was that regardless of the agents used to treat the patients before they went to surgery, the likelihood of complications was not statistically different. Numerically worse with steroids, but not statistically different. All of our patients go to staged proctocolectomies for J-pouch creations. And so I think the message here is when you make the decision to do surgery, do it the right way, work with your colleagues who are smart surgeons and can help you. So I'll summarize by saying that we've made some progress in the understanding of acute severe UC, even if we don't know what causes it in most patients. Looking for infections early, treating C. diff empirically while you're waiting in some cases, making sure you're not missing a 5-ASA intolerance, which is a simple maneuver that can help. Try to figure out, are you having trouble inducing or trouble maintaining remission, so you can make some decisions about treatment options. Don't give steroids longer than 3 days. If they're not working, move on to something else. And I think that cyclosporine versus Infliximab or any anti-TNF agent is now a very relevant question as we start to appreciate the pharmacodynamics of these agents. There are not sufficient data yet for Veto in the inpatient severe setting, nor is there for the injectable TNFs. So if you have a hospital that for formulary reasons is making you use one of those, I would encourage you to make sure you have a discussion with them about the evidence and what evidence there isn't. And then lastly, remember the importance of a staged colectomy, because overall that will lead to safe outcomes. Thank you very much.